talk, which is by Dr. Alec Miller. Dr. Miller is going to be talking on the advances of DBT in research and treatment, and we are so shifting from kind of internal state to external and looking at behavior and skills and the effect of DBT. And Dr. Miller is the co-founder of Cognitive and Behavioral Consultants of Westchester. He's also a professor of clinical psychiatry and behavioral science. This is at the Montefiore Medical Center and Albert Einstein College of Medicine in New York. Okay. Welcome, Dr. Miller.
Well, it's a pleasure to be here, and I want to thank my course coordinators, Perry and Blaze and Robin. And I think in the name of mentalization, I'm going to try to mentalize for my first official time and say that while we're waiting for these slides to come up, I'm wondering if you're feeling the urge to stretch your legs and your back. And if I ring the bell, could we do a brief mindful stretch exercise with no talking, but that you could, if you so desire, stand and stretch. And I will ring the bell to conclude the stretching. This doesn't mean everyone evacuate the premises, because I'm about to teach in 30 seconds. But just for 30 seconds, stand in place and we'll mindfully stretch. Wonderful, wonderful, thank you. I hope that was helpful. So we're shifting gears. We're going from mentalization-based treatment to dialectical behavior therapy, and I have my kind of key points I'd like to highlight in today's presentation. The first is this issue about diagnosing BPD in adolescents, and I want to talk about that. And then I want to discuss why bother learning any new treatment at this point in time. I'd like to talk then about the comprehensive nature of DBT, the biosocial theory that underlies the treatment. I want to give you a brief primer on the current research in this area, which I'm excited to share with you, and then a few words on future directions. Now, dialectics involves taking seemingly opposite constructs that can be true at the same time and then create a synthesis and then a superordinate truth. Diagnosing BPD in adolescence, I think, in my experience, fits into that a little bit. For many years, I've been a strong proponent of sticking to diagnosing, applying the diagnosis to teenagers, if appropriate. And I've written about that extensively, and I really feel that in order to help the kids get proper treatment, it helps to have the right diagnosis. I also feel like in order to destigmatize BPD, we should give the diagnosis where appropriate as well. So for many years I've been kind of promoting that. But I've also realized over time that in the treatment that we deliver in DBT, it almost doesn't matter at the end of the day what the diagnosis is, if in fact you have a broad range of dysfunctional target behaviors that map on to the treatment that we're delivering. So if you have real problems in emotion dysregulation, if you have real problems regulating your behaviors, if you have real problems in interpersonal relationships, if you have real difficulty identifying what you're feeling when you're feeling it, if you have difficulties navigating the Grand Canyon with your family, then maybe in fact DBT fits well with that problem profile. And so I don't want to get attached to the diagnosis of BPD, because if you have those problems, it doesn't actually matter. We have people with bipolar disorder for whom this works. We have people with depression and substance abuse and real interpersonal difficulties. So there's possibly, the middle path is, I'd like to see if the diagnosis applies, because for those people, for sure, we want to consider DBT, and now we have data for MBT for sure. And for those who have multi-problems, who don't necessarily fit the exact bill, I'm not so attached to the diagnosis either. So that's the synthesis. It may be both and. In DBT, the central problem for these individuals is emotion dysregulation. And if one has trouble regulating their emotions, they have this cascading set of difficulties in other domains of function. So the white lines, of course, many of you realize, represent the 9 criteria of BPD in the DSM-4. And those yellow headings are the 5 major areas of dysregulation that we're targeting in DBT. So emotion dysregulation, interpersonal dysregulation, self, behavioral, and cognitive. And so the way we translate that into layperson language for teens and families and young adults that we work with is confusion of self-dysregulation or confusion about self. And for those of you who are rather new to this treatment modality, what we're talking about here is we're trying to teach them mindfulness skills, and I do think there's some interesting overlap and interplay between mentalization and mindfulness, which is worthy of some discussion, I think. But in this case, what we're talking about here is attentional control, how to train your mental camera lens to stay focused on this task at hand, as well as enhanced awareness of your experience in the present moment, being non-judgmental and fully participating. So how can you be aware of this present moment, and how can you stay focused in this present moment? And so that's a lot of what our individuals in DBT are learning. And we're teaching these core mindfulness skills to better help them participate non-judgmentally in this experience and have greater self-awareness of their experience, so they notice their urges and their emotions, and then they can use these other sets of skills that come next. But without awareness, you have no chance to actually affect using these other skills, because you don't know, it's too late. The wave has overcome you and it's too late. We're also going to be targeting impulsivity or behavioral dysregulation with distress tolerance skills. We're going to target this emotional dysregulation with a whole set of emotion regulation skills, interpersonal difficulties, a host of interpersonal effectiveness skills, and then these adolescent family dilemmas, which has a lot to do with cognitive dysregulation, where you get very polarized. I'm right, you're wrong, I'm good, you're bad. Again, these opposite sides of the Grand Canyon, and how to navigate that. And so we developed a set of skills called Walking the Middle Path skills, which I'll go over in a few minutes. Now, I guess the question I have for providers and consumers is, why bother learning a new treatment or delivering and receiving a new treatment for BPD? And I guess, for adults, it's not so new anymore, but for adolescents, it's still rather a new treatment. And I think the answers to me are, one, you just don't know any treatment for this population, so why not learn one or get one? Secondly, the old one doesn't work. Thirdly, maybe the new one has better outcomes. Or the new one has same outcomes but is more efficient, may be preferred by providers and consumers, and may feel more humane. So my rationale to do DBT for teens many years ago were that there were very compelling data with adults that suggested that DBT was more effective than other treatments for borderline personality disorder teens. In the last 10 to 15 years, as I'll show you a little later, we now finally have some randomized clinical trial data on adolescent DBT for BPD. We have quasi-experimental data and open trials, of course, which we've had for a long time. And just a few months ago, as you just heard, Rousseau and Fonagy published the first paper on adolescent BPD on a randomized trial showing reductions in deliberate self-harm, which is very exciting. In addition, what I love about DBT is the biosocial theory that is a theory that offers a lot of compassion for the explanation of the etiology and the maintenance of borderline personality disorder to our clients, to our families, and to other professionals. And the theory, as I'll show you, directly informs the treatment targets. So we'll discuss that. The other thing I like about DBT in this way is that it's skills-based. And for many kids and young adults who are accustomed to going to school, we're teaching very kind of concrete skills that they can begin to practice and rehearse, and so that they can generalize these skills to their lives. And we do that in a skills curriculum, which I want to show you. And lastly, it's a multimodal treatment. So it affords us multiple entry points into these teens and young adult lives. So there's individual therapy, as you'll hear. There's a multiple family skills group, which I want to talk about. There's family therapy sessions as needed, and there's definitely in-between session coaching, both for the teens and for the parents. Now, oftentimes where I live in New York, there are community therapists who refer clients to me and say, I'll do the therapy and you can do the DBT. And I've gotten a little tired of that call because the implication is that the therapy is everything else and the DBT is just the skills. And what I wanted to talk about for a few minutes is to kind of describe the comprehensive nature of the treatment and the structure of the treatment. So many years ago, Marshall Linehan identified 5 functions of a comprehensive treatment, and these are, here they are. Number 1, and think about this wherever you're doing your treatment, if you're working with multi-problem, borderline spectrum, young adults and youth. 1, are you doing something in your treatment to enhance their capabilities? Are you giving them new tools, new skills, so that they can kind of work with what they have and then build on that? Certainly psychiatrists can do that pharmacologically, but psychologists and social workers and folks from other disciplines are going to teach psychosocial skills, and we do that in a skills group. To improve motivational factors, many of our folks, for various reasons, get stuck, and they have trouble with their sustaining motivation. So somebody in your treatment has to be targeting their motivational deficits, because just like they said they'll be in treatment, yeah, that sounds good, sign me up today, 2 days from now, a week from now, you know what, I just changed my mind, I don't feel like this is not for me anymore. Who's going to address that? And so in DBT, that's the individual therapist. Thirdly, how are we going to take the tools and skills we're teaching in a skills group and having them generalized to the outside world? It's all well and good to come to group on Wednesday nights. We're going to have fun, we'll have some laughs, great, 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 but how do we get these tools into your life? At home, at work, at school. So the way we do this in our treatment modality at DBT is to have coaching. And I literally carry around my pager so that if they need to figure out what skills to use to avert their problematic behavior, whether it be self-harm, whether it be substance abuse, whether it be punching a wall, whatever else, I want them to, first of all, try the best to use some skills that they've already learned. But if and when those don't work, they should call for coaching before they engage in problem behavior. So I want to generalize the skills to their outside world. And of course, when I teach this, many people say, you know, it sounded interesting until this very moment, but now you're saying, are you saying, Alec Miller, that you are available 24/7 to your clients? Is that exactly what you might be saying? And the answer is, I am within limits. So for example, I'll be teaching this morning, and I'm not going to be taking any calls, but if I get a page, and would be fortuitous just to demonstrate this, I'm not going to call them back until I have a break. And there's certain parameters about for what reasons to call, but I am available at 24/7. And there's a certain degree of commitment, I guess, for suicidal and self-injurious clientele, that if you're going to do this treatment, you're offering your availability. But I can still go to Broadway shows in New York, I can still go to parties and have a cocktail, and it doesn't control my life. I just want to put that out there because some people say, you must be out of your mind. I just want to clarify that. Structuring the environment. It's also, I think, very important that when you work with teens and young adults that we have to figure out a way for them to get access to the care, for the families to be involved, and for myself, who's the program director in my center, to make sure everyone has time for team meetings, for supervision, and that we can kind of have protected time to deliver the care that we're proposing in this multimodal format. And last but not least, and certainly not least, is we need to figure out a way to enhance the therapist's capabilities and their motivation to treat effectively. I'm sure if we did a raise your hands, which I'm not going to do at this moment, but if we did, I'm sure many of the people in this room have experienced therapist burnout in your careers. There may be a single client or multiple clients who are challenging, you know, maybe calling you names, saying they're going to rape and pillage at your house and so on, where it can affect your focus and treatment. And so we have a place to go every single week, which is the therapist consultation team, where we provide support for each other and basically supervision and therapy for the therapists so that we stay balanced and not too change-oriented and not too acceptance-oriented, and make sure we're delivering the care as it's prescribed and adherently. So these are the modes of treatment as we developed them years ago specifically for teens. And I think there's really some major league value in including the family members and caregivers into the skills training group. Because even if the parent or grandparent or aunt or uncle or whomever the caregiver is identified is high functioning, doing quite well in kind of transaction with this individual, sometimes the skills go by the wayside. And there's real advantages to kind of learn these skills in the curriculum together, have the same language, have an evening together where you spend in a therapeutic context. And we found great value in making it a multiple family skills group with 4 or 5 teens, and then usually 1 or 2 of their caregivers. So it could be a 15-person group for 2 hours a week for 20 weeks or so. Then there's an individual therapy, as we talked about, where you're really kind of targeting motivation. You're doing behavioral chain analyses and solution analyses to figure out what is the controlling variable in the links on the chain that cause the individual to go this way and self-harm versus this way and manage their emotional distress without self-harm. And so we do a lot of these chain analyses, we call them, and work with kind of replacing the maladaptive behaviors with adaptive behaviors and give them homework to work on that during the week. Thirdly is the telephone consultation, and there's 3 reasons to call the therapist. Number 1, I want you to call me before you engage in problematic behavior. It doesn't help to call afterwards because you've already decided on how to cope with that problem, albeit maladaptively probably. So it's not helpful to call after. Call me number 2 if you have some good news, because I would love to hear some good news from time to time. And actually, I'm thinking strategically, I want to extinguish the relationship between crisis behavior and therapist attention. So I will welcome some, a call or an email or a text about some positive news and really reinforce the heck out of that. And thirdly, I want to repair the relationship. If there's any kind of potential breach where the client feels like I was pushing too hard, they felt upset by something I said or did, I don't want them to wait 7 full days to say, Alec, I was really hurt by that, I was really upset by that, or they might have felt ashamed by the doorknob comment that they made on the way out, that they hate me and I suck and they're never coming back again. Because many of our clients have prone to feel intense shame. It's a common emotion for individuals with BPD, and shame also is highly correlated with suicidal behavior, and shame is also highly correlated with dropout, because you're avoiding and escaping things that you don't feel good about, so you're not going to show up again. So I want to make sure that if anything comes up therapeutically, we're going to have a chance to talk about it before it festers and gets too far down the road. So those are the 3 reasons to contact the therapist. And we found over the years that when we incorporated the parents or caregivers in our multifamily group, we offer coaching for them too. So after hours, if they and their young person in their lives are getting into it, I want the parents to call the skills trainer for coaching and say, what should I do? This is really distressing me. Remind me what skills to use. Now, when I first started doing this back in '95, I had the fantasy that we just bring the parents in for skills group and that should do it, and they'll be good to go. But I realized that a lot of the challenges for many of the teens, not all, kind of erupt in a family context. And I thought, okay, you know what, we better bring the families in and let's kind of talk about it. And for many of the families in the room, you come into the first therapy session with your new clinician and you have the legal pad of all your laundry list of concerns you have about your loved one. And you start to kind of make, organize, and you want the therapist to know, okay, here's the history, and here's all the problems we're having. And can you help us with this, and this? And I'm writing notes down, okay, I got that. And meanwhile, the young person, the adolescent in the room is now starting to get more dysregulated and kind of feeling like they're going to start running out of the room. And before we know it, I'm chasing the kid, and the parents say, see, this never is going to work. And the kid says, I told you this is never going to work. And then we have a full-on catastrophe. So it occurred to me after a couple of years of doing that maybe what I should do is, instead of just having the rattling off the laundry list, of course I'll get some history in the intake, but I really want to have the first family session devoted to talking about how we're going to talk about the problems. Let's talk about validation skills. Let's talk about how to communicate effectively with each other and non-judgmentally before we start rattling off the list of problems and trying to solve them prematurely. And that has saved a lot of fireworks for me and the families I work with. It's kind of just, they're chomping at the bit in some way because they want help desperately and they want to validate that. But I think until we can talk about the difficulties effectively, it may be premature. So we ease into that. And lastly, the therapy for the therapist is so critical. I think the therapist consultation team has kept me going now almost 20 years doing this, because I think there's so much potential for burnout, there's so much potential for doing non-therapeutic things as a therapist. If you're not having peer supervision and kind of getting feedback, you yourself, your own therapeutic compass can get kind of twisted around without adequate support. So those are the kind of the primary modes of DBT with young people as we develop them in an outpatient setting. And you'll hear more about residential settings and other settings as well. Now, that's phase one. But as many treatments have been demonstrated with depressed youth over the years, you'll have a kind of an acute phase of treatment. But if you don't have some continuation phase or maintenance phase of treatment, what ends up happening is you have dropout. You have kind of a regression or kind of relapse, rather, to prior problematic behaviors. So we came up with this idea of developing the graduate group, the DBT graduate group for teens. And this is truly the clinical highlight of my week, I'm happy to report. It is such a pleasure to be able to have teens now who've kind of acquired the skills, been taught in the first 20 weeks, but not necessarily as strengthened and as generalized as we'd like. So they come in, no more parents now, this is a teen-only group. Everyone rotates leading a mindfulness practice each week, someone else, the teens lead as well. We do a brief skill review where one kid gets up at the board for 10 minutes and reviews one of the skills. And I mean, so one of my jobs is in the Bronx in New York. And to see these kids in the inner city, many of whom have had many life challenges, socioeconomically and otherwise, to stand up and write on the dry erase board about mindfulness and about emotion regulation skills. I'm ready to retire. I feel so satisfied because to see this happening is such a reward for me. And then the rest of the group is devoted to peer consultation, where they're really working on consulting to the others, using DBT skills and language. And for a lot of them, they're pretty isolated and have a lot of peer difficulties for a variety of reasons. So to come together with like-minded peers, consulting to each other, is absolutely rewarding, but more importantly, is skill strengthening and generalizing. And I think we see many kids kind of in that mode only, no more individual therapy at a certain point, and then they can get off to college. So that's a really nice format that we've used. This is just a schematic of how our groups run typically. You have 4 different entry points. If that's a face of a clock, you can enter at 12, 3, 6, or 9 o'clock. And orientation of mindfulness involves teaching the biosocial theory, which I'm going to go over with you, going over the assumptions of the treatment and the format, and then spending 1 or 2 sessions on that plus introduction to mindfulness. And 4 sessions on distress tolerance. We have a new entry point again, and then 3 or 4 sessions on walking the middle path skills, and so on. So that's kind of the format. I can answer more questions if you have some. Now, what Jill Rathis and I discovered after adopting Linehan's original adult manual was that there were several skills that seemed to be necessary in working with teens and families that were not part of the original treatment. And that was, we needed to really teach and practice dialectical thinking and acting. And we found certain dilemmas, which I'm going to describe to you. We felt we needed to teach behavioral principles to teens and families who also had very little understanding of what positive reinforcement is, what's extinction, what's effective punishment, ineffective punishment. And really, I think most importantly, was we had to spend more time teaching individuals and families about validation of other and validation of self. And I'm going to spend some time going over that. Here are a few of the dilemmas, just to highlight briefly, that we realized that many of the families we were working with were vacillating. When you have intense emotions on board in family systems, you can oftentimes see extreme behavioral kind of maneuvers. So sometimes we had some parents, some of them were single parents, who were kind of excessively lenient. Let's say they had several kids in the home, and the oldest was the identified patient, 16 years old. They were kind of running the house. The parent was managing the 3 younger kids and trying to get by. And then at one point or another, the kid did something that crossed the threshold. The parent had little patience at that point and swung from excessive leniency to authoritarian control. Do I have the pointer here? I don't even, you have it? Okay, no worries, don't worry about it. But anyway, my point is they would swing, and then the parent would say, you know what, you are grounded, this is it. You're done for the next few months, no more screen time, blah, blah, blah. And the teenager says, screw this, I'm not listening to this. They run out of the house, they violate all the new rules, and the parent throws up their hand and says, I guess this isn't working, and swings back to excessive leniency. Thank you, Ron. So there's a lot of kind of swinging. And again, sometimes you have normalizing pathological behavior versus pathologizing normative behavior. You have forcing autonomy versus fostering dependence. So there's certain behavioral patterns that both the parents may swing to and from, or land heavily on one side or the other. The teenager may swing between the poles, as well as therapists are equally guilty of sometimes swinging as well. And there's a lot more to be said about this, but I don't want to get too sidetracked on the dilemmas right now. I want to kind of give a few moments to discuss the assumptions about clients, families, and therapists too. For every group we run, I ask the most disgruntled parent or caregiver in the room to read assumption number 1. I say, Mr. Smith, can you read this one? People are doing the best they can. Now, if you've been through the life and ordeal that many of the families have gone through, you feel many of the families we work with are feeling so burned out themselves and just at a loss. And so they are not typically thinking and have trouble acknowledging that people are doing the best they can. But when I frame the question as, Mr. Smith, if Jessica could have figured out, was dreaming about her adolescence, do you think she was thinking, I can't wait to be in DBT with Alec Miller on Wednesday nights and go to individual therapy and have to do DBT skills homework? Was this her dream adolescence? And usually the answer is no. So then the question is, well, if Jessica could do better and figure out a way to have navigated her life to not require hospitalizations and wilderness programs, I think she probably would have. So by definition, I'm going to go and say that I think she's doing the best she can, because if she could have done better, she would have. And if she can do better, she will. And that gets to, I also think, though, Mr. Smith, that people need to do better, try harder, and be more motivated to change simultaneously. And this is my first opportunity to kind of introduce one of the core dialectics of the treatment, which is that Jessica is doing the best she can, and at the same time, she really needs to do better, try harder, and be more motivated to change. And I think I'm highlighting that both of these things, seemingly opposite constructs, can coexist and be true at the same time, and forms the overarching dialectic in DBT. But I say, by the way, Mr. Smith, I think you're doing the best you can as a father of her, Jessica. And I think there's probably things you can do to improve your own behaviors as well. And so I'm going to say that 1 and 3 are true of you. And I myself, as your friendly neighborhood DBT skills trainer, am doing the best I can tonight teaching you the skills. And I have a feeling there's things I probably could have been more clearer about a few moments ago too. So there's probably things I could do to be more effective next time too. So these assumptions are applicable to everybody in this room. All right? And so people want to improve. I think we really want to kind of imply that we believe in that kind of underlying drive to want to improve. And just because they haven't caused all of their own problems, many of these teenagers and young adults still need to solve them anyway. Yes, life isn't fair. Yes, that sucks. And yes, you need to figure out a way to do this. We're going to help you, but you have to take some responsibility and accountability to work on this too. We want to validate the fact that the lives of suicidal and depressed teens are painful as they are currently being lived. We want to make crystal clear that while we may have a good time here on Wednesday nights and talk about all kinds of skills, unless you learn and unless you practice new behaviors in all the relevant contexts of your life, very little change is going to come. Right? I mean, you can sit through any class in math or English or science. If you don't go, or piano or drums, if you don't practice, your skill set is unlikely to go and get too far along. And last but not least, we don't think people can fail in DBT. In no other field of medicine do we tend to blame the patient for their lack of progress. We have really mastered that mental health, I must say. I can't be more proud of us. Right, if you have a patient with a brain tumor and they go to Sloan Kettering, can you imagine the oncologist saying, you're clearly not trying hard enough, it's not shrinking, you're doing something wrong. What are you doing? What's the problem here? Right? They might say, why don't we try another form of chemo, why don't we add some radiation? Right? But in mental health care, if someone's not benefiting from your intervention, it tends to be the patient or the family's fault, which is very upsetting. So we basically tell our families, if we think this is an effective treatment for many people, but if you're not responding, we're not going to blame you. We're going to see there may be something else that might be different, including MBT or other treatment as well. Now here's the theory that underlies DBT that I think really treats the therapist, helps us better kind of empathically, phenomenologically empathically understand our clients. But I think it's equally important for the clients to understand the theory, for the families to understand the theory. And I've learned now over the last 5 or 10 years that there are a lot of other people that really need to understand this theory. And that includes school personnel, that includes medical doctors of kids who have medical conditions, who are inadvertently invalidating left and right, as I'll tell you. So there's usefulness to kind of promulgating the theory and disseminating the theory to kind of have more empathy and compassion, and then inform how we're going to treat the kids. So many of you have probably seen this slide before, but it's a transactional model, basically, and I teach this as I'm teaching you, as I teach to the teens and parents as well, that we believe there's a biological dysfunction in the emotion regulation system. As you heard from Dr. Bleiberg, and you know from others, there's an increasing mounting database about the neurobiological differences in people who have BPD in their brains compared to non-BPD individuals. And there's more data now with adolescents as well. And let me just see if I have the next, so I'm going to show you some of the characteristics of that in a minute. So you take someone with this biological dysfunction and you put them in what we call an invalidating environment. And this environment, as I'll describe to you, is not just families. It's peers in schools. It's teachers. It's coaches. It's other doctors. So over time, if it's pervasive invalidation coupled with this biological vulnerability, you have the potential to yield emotion dysregulation and the sets of problems that we see associated with BPD. Now, this emotional vulnerability has kind of 3 main characteristics that we talk about in DBT. One is that these individuals are highly emotionally sensitive, so things get under their skin more easily. Now, my son, he has unbelievable allergies, and so even though it's been fluctuating in New York between 30 and 40 degrees, but it's on the precipice, as you know, of springtime, you can see some buds coming out. He's already showing signs of sneezing and itchy eyes, and it's in the 30 degrees this week. So it's incredibly sensitive. So the individuals with BPD have the same sensitivity to their emotions. The things that don't register for many of us are already starting to be experienced by many of our clients. They get under their skin much more easily. Then you have high reactivity, and as many of you know, individuals with BPD have much more extreme reactions. They are more the dramatic people of our society, and they have powerful emotions, which I think are many assets to being powerfully emotional people. I think they're very charismatic. They can be very persuasive and passionate, and so there's a lot of pluses there. The problem is when it gets too extreme, the behavior gets more extreme, and so the thinking processes get very dysregulated as well. And so they get into much more extreme ways of thinking, or non-dialectical, all or nothing, black or white kinds of thinking, and then the judgment goes out the window. And as well as having trouble processing new information. By the way, I loved your calculation earlier of the 3.5 minutes. I want to know the calculation of the guy who speaks after you for an hour, and what do I get down to about 1.5 minutes? Okay, so, all right, so just to be aware of that. So the cognitive processing, which triggered my mind, is also impaired when the emotions are so dysregulated. And thirdly, is this characteristic of the slow return to one's emotional baseline. And for many of our clients who get aroused emotionally, it takes them a long, long, long time, sometimes hours, sometimes a day, a weekend, before they come down to baseline. So imagine you have those 3 characteristics. Okay, and then we talk about an invalidating environment. An environment that includes family members, school staff, having worked now in DBT in schools and having school-based mental health programs, I've gotten a real inside look at what's going on with our children when we're not there. And it ain't always so pretty, I must say. I mean, the screaming, the decibel level of the teachers in the elementary school that I worked with in the Bronx was very distressing to me. And it's not just teachers, administrators, security guards, it's pervasive. It's pervasive. So it's very concerning to me how invalidating some of the environments in which our kids are spending much more time with those folks than they are with us, are getting exposure to that, not to mention their peers. And there's more and more interesting data and concerning data about the impact peers may have on our kids' mental health, including sometimes being a precipitating event for self-harm and suicidal behavior too. Having worked also in inpatient settings and other outpatient settings, I've seen mental health professionals who can be pretty invalidating toward their clients as well. And certainly medical doctors, we've recently gone into the Children's Hospital in Montefiore, where they work with kids with all kinds of chronic medical conditions on an inpatient, outpatient basis. And these days, as many of you know, most specialists or even pediatricians have approximately 3 minutes to evaluate and treat their teen. So they come in with so a 15-year-old diabetic adolescent comes in, and the doctor says, "What are you doing? Your insulin levels are out of whack. You're going to have DKA and go into coma. What are you? I mean, do you want to die? Are you trying to kill yourself? What is the matter with you?" Now, the doctor is trying to quickly and trying to effectively get this young person to be more compliant with their insulin regimen and their diet. How well is that working? Not so well. So there's major problems with how doctors and nurses are interfacing with our kids. And we have kids who have chronic kidney disease who have been taken off the transplantation list. Why? Because they're non-compliant with their medical appointments, they're non-compliant with their medical regimen. So they've been removed, so now they're on the blacklist. And I'm going to show you with a brief DBT intervention to help kind of get those kids back in the fold and get them back on the transplantation list. Because they just have given up on their medical care. They're fed up. They don't feel like anybody gets it. So some of the characteristics of an invalidating environment. One is that the environment sometimes indiscriminately rejects communication of the individual's experiences or behaviors, right? So the more extreme versions of this, if a teen, let's say, is upset about failing a test, teacher or parent might say it's your fault. If you studied more, you would have passed. But you know, that doesn't sound terrible. You can imagine much more extreme versions of invalidation in various contexts. You're lazy, you're manipulative, you don't give a shit. Why can't you be like your brother? Much more intense, judgmental, invalidating statements that can be made by anybody, okay? So that's, or a more benign version of that, and I certainly can imagine being guilty of this, and other parents in the room. If you have a teenager who's upset about failing a test, parent might say, well, stop worrying, honey, it's not a big deal, it's just one test. Now, doesn't that sound so sweet and lovely? It's not a big deal, honey. Don't worry. It's okay, right? Now, you know, it seems like you're going in to soothe and to validate. But if the individual who feels so distraught about this test that was important to them, and they had, let's say they had studied, and let's say they had worked, and they still failed the test, for you to say it's not a big deal when they feel it is a big deal and it's important to them is an inadvertent invalidation of their present experience. All right? And a poor match, if you will. It doesn't verify their experience at all. Now, when I teach this, many parents say, well, what are we supposed to say? Bravo, you failed your test. You mean, what should we be doing? No, we don't want to validate the invalid, but it behooves caregivers to at least acknowledge the individual's location perspective of, I can see how sad and disappointed you are about failing your test. Put a little period there. Pause and breathe. And then at some later point, you might go in to figure out what got in the way, where they did fail the test, and what do they need help with. But don't rush in so quickly prematurely, is to kind of figure out some change strategies there. Number two, sometimes another characteristic is ignoring or punishing lower levels of emotional displays, and then intermittently reinforcing emotional escalation. So many years ago when I was an intern on an inpatient unit, before I learned anything about DBT at all, I had a patient who had borderline personality disorder, an adult patient on the unit. And the nursing staff paged me when I was off the floor and said, your client is out of control. So being the obedient intern that I was, I said, oh my, okay, well, here I come. I put on my cape and I flew into the unit, not knowing having the faintest idea what I was about to do or see. So I show up, and it already had transpired, because the 5 minutes off the floor, it happened. And what happened was my client basically asked the nurse, may I have a PRN, please? May I have just a little, my Klonopin or Ativan or whatever it was at the time? I'm starting to feel a little dysregulated, I could use that. And the benevolent nurse said, I'd love to help you, Sally. I just have to take the blood pressure down at the end of the floor, and I'll be right back. So my client is pacing around the nursing station. 5 minutes goes by, the nurse doesn't come. Another nurse shows up. Nurse, can I have my PRN? I'm starting to feel a little ramped up, Sally, hang on a second. We have a little crisis down the hall. Someone's having a little problem. I need to get to that. Okay, 5 minutes later. 5 minutes later. Now my client, this is 10 or 12 minutes later, is not getting attended to at her lower level communication. And what does she do? She blows up, and she ends up having a major emotional meltdown where she starts swiping everything off the nursing station desk onto the floor, screaming and writhing on her back. And you know what happens next, which is the most amazing thing, of course, is that a white cup with a little water and another cup with a pill shows up just like that. Now, I'm not saying Sally was consciously saying, if I do this, I will then get my medicine. I believe she just couldn't handle her emotions anymore and lost control. But what's on the unfortunate consequence is that we inadvertently, intermittently, reinforce that level of emotional dysregulation, and we sometimes are not attending to much lower levels. And we're all guilty of this, right? I mean, again, my kids are getting older now, but when they were younger, I would hear them, bantering in a kind of slightly tense way, and I would kind of ignore it, and hopefully they'd reconcile. And then I'd hear somebody scream, Ian! And then I'd say, Ian! And I would start running in, to kind of address the same situation. I missed the lower level communication, and I tended to the higher level communication. And that's when my children got my attention. I was happily typing away on my computer, and that's when I tend. So with our clients, I think we need to, and again, I'm not expecting perfection, and I think sometimes, as Efren said, sometimes having miscues and not always validating and not always attending is probably a good thing for their emotional development. But I think as a general principle, if we can think behaviorally of what level of arousal we're attending to, and try not to only wait to the escalation. I mean, it happens in schools all the time. The students are having difficulties, and they have one word, and then they go right to the emergency room, and everybody whisks them off. Right, as I'm starting to feel suicidal. Oh, okay, so now let's help you right now. Let's get you into a private session. I had a private patient for a long time who was starting to get better. And she said, you know what's really frustrating me, Alec? I said, what? I said, now that I'm starting to feel better, my school therapist kicks me out of her office when somebody who's more upset needs her help. So she's getting less service in school because somebody else amped it up, and so she's now getting less attention. So we just have to be careful about ignoring or punishing lower levels of communication and reinforcing higher levels. Another example, I guess, tied in with the above, is you're overreacting, it's not that big a deal. And then the crying escalates, and the teenager says, I'm not going back to school. And then the caregiver says, whoa, okay, well, you know what we can do? Let's go out for a nice dinner tonight, you'll feel better, and then I'll help you study next time. So, okay, I'm going to treat you a nice dinner, I'm going to be your study guide, and then it's all good. So when you start threatening, we're now giving more reinforcement. So just to be mindful of that. And the third example of this characteristics is the oversimplification and the ease of problem solving. Just study more next time or you'll do great, and you'll do great. Don't worry, be happy. Or my other example of the Nancy Reagan approach. Some of you may remember back many years ago, the first lady of our nation came up to the podium, and every first lady has their platform, and said, "Okay, ladies and gentlemen, as your first lady, I am here to tell you I have a solution to the substance abuse problem that is plaguing our society. Are you ready for this? Brace yourself. You better have a seat because you will pass out when you hear this. Here it is. Just say no." Thank you. Thank you. Thank you. Now, just say no. Okay, can you imagine a 20-year substance abuse addict hearing that? Just say no? Okay, thank you. That's fantastic advice. But we, as therapists, sometimes inadvertently communicate to our clients, just do this. I had a kid who was out of school for a while, was anxious about going back to school, and he said, "What should I do?" I said, "What you should do is just go to your guidance counselor, tell them you're back, you want to figure out about your what you missed and how to be caught up, and they can tell the teachers that you're back, etc., etc." And he's like this, okay. Now, that bobblehead situation, I should have known, is sometimes not really affirming or validating what I'm saying, but just trying to please me. And sometimes we overestimate the ease, and by the time we're saying just do this, because I could do that, I have that in my skill set at this stage of my life, but not everybody does. And so it behooves us to really say, is that something you feel you can do? Is that in the range of possibilities? And looking at what might get in the way and not oversimplifying the ease. Because the consequences of doing all these things, number one here, if we continue to reject communication of private experiences, the individual over time may begin to self-invalidate. And if you're pervasively invalidated, you begin to internalize that. You begin to believe that you shouldn't feel this way, that you are overreacting, that there's something wrong with you. And you do internalize that invalidating environment, so you become your own worst invalidating environment. I shouldn't feel this. There's something wrong with me. And you begin to search for cues outside of yourself because you don't know, your judgment about what is appropriate experience is not clear. So I need to figure out is this funny or is this sad? I don't even know. Am I supposed to be laughing or am I supposed to be crying? Let me take a survey of my classmates to figure this out. There's very little self-awareness and self-judgment. And so one of the targets of DBT individual therapy is to help individuals mindfully observe and describe their feelings and then validate them. There's no rule book on what you should or shouldn't feel. I just want you to be able to acknowledge that it's okay to feel this way. How you act in accordance with that, we're going to talk about. That may be a major problem. But your feeling is your feeling, okay? And you're entitled to feel that. And remember my young lady Sally on the inpatient unit, if we ignore or punish lower levels of emotional displays and then intermittently reinforce emotional escalation, what ends up happening is you have this oscillation between extreme emotional inhibition and then extreme outbursts and emotional styles. And of course, with Nancy Reagan and the rest of us, if we tell them just do this, do that, the clients may begin to form unrealistic goals and expectations. And one other aspect of this I just wanted to briefly highlight is the transaction between the child and the caregiver or the teacher or the therapist over time. So imagine, and my example of this is little Johnny who's 5 years old. He's wired to be hyperactive, he's intense, he's active, he likes to bounce the balls in the house. That's Johnny. Mommy says is more on the subdued, depressive side and doesn't like too much noise in the house. Johnny's bouncing the ball. Mommy says, "Johnny, quiet in the house, please. This is too much." Johnny tries to inhibit and suppresses his urges. Okay, I've got to be a good boy. I'm going to try to keep it down. But then Johnny, he's wired the way he is. He said, "I don't get this. This is who I am. Why can't you accept me from all my ADHD and my beauty with that?" And so he starts bouncing the ball again and throws it against the wall. "Johnny, that's it. You better, if you keep doing this, you're going to go up to your room." Okay. So he tries to pipe it down. And then Johnny unleashes the ball, hits Mom in the back of the head. At which point, now you're definitely going to your room, and now you're not going to see daylight for the next 12 hours, right? Whatever. It's extreme. I'm just exaggerating. My point is, sometimes it's a poorness of fit and temperament that we've seen with some of the families we work with, where Mom is not a born invalidator, And Johnny has his wiring too, but they are totally not in sync. And I've had many parents say, you know, I feel like 3 out of my 4 kids I totally get, I can parent, it makes sense. This 4th kid, I don't know what the heck's going on here. I don't know how to effectively deal with this relationship and effectively parent this child. And sometimes it can be temperamental differences, and what works for the other 3 just doesn't work for this. And it just tells us we need to figure out other strategies, including validation strategies, that may be necessary to help navigate this. So, in terms of teaching biosocial theory to patients and families and teachers and mental health professionals, including milieu staff, I really do think it can instill genuine hope for self and other when you learn this biosocial theory. It helps to reduce blame. Kind of, how could it be otherwise? Many of the parents I work with have said, well, no one validated me when I was growing up. Well, I said, you know, then how could it be otherwise then that you don't have the validation skills to kind of pass on to your child? But the good news is, we're going to teach you all validation today, and we're going to work on being more effectively validating towards others and self. Okay? And then it kind of points us to the intervention points, right? So the bio piece has a lot to do with teaching emotion regulation skills, and the invalidation piece has a lot to do with increasing validation. And my take home for the therapist in the room is that when you get anxious and you feel like I have to dampen down this out of control behavior, there's a real tendency to kind of manage your anxiety by clamping down and telling them they should do this, they should do this, they should do this. And I really do think that we rush through the opportunities to be more validating of their negative affect and kind of slow ourselves down and linger with that and acknowledge their experience before we rush in with all your change and behavioral strategies that I think they need, but not as early as you probably are doing. And I do think a lot of the families that need a lot more validation as well, and you're going to hear a lot about Family Connections today, and other programs where we can help parents and families get more support and validation about the experiences of working with individuals who have BPD, because it is extremely challenging, and without the right skills and support, you can burn out the families as well, as we talked about. So we've been doing a lot more parent coaching and support with their families. Now, relatedly, in terms of DBT, if you dissect this slide and a half, on the right side are all the acceptance strategies, and on the left side are all the change strategies. And we spend a lot of time kind of consulting to the client about how to navigate the environment rather than consulting to the environment about how to navigate the client. Because I think in some ways, if we don't do this, we're actually inadvertently going to be cultivating more mental patients than we want to. I think there's such a pull for teens for us to rush in and solve their problems for them. Alec, can you call my school for me? Can you tell my mom this? The answer is, of course I can do it. The question is, I don't think that's effective for me to do all those things for you. I want to teach you how to fish so you can eat for your lifetime. I want you to figure out the tools on how to do this so that it's not constantly being done for you. Now, let me show you, in the few minutes I have left here, there's definitely some work I told you about with chronic medical conditions. There's definitely a lot of interesting work that's being done in DBT in schools, and I'm really excited to kind of think about this from a primary and secondary prevention standpoint. How do we teach these life skills to 4th, 5th, 6th, 7th, and 8th graders, get it into elementary and middle school, so maybe we can avert the many problems that our kids are engaging in by the time they get to adolescence and young adult, and I'm happy to discuss this more. But what I wanted to share with you in the couple minutes I have left, I had the pleasure of chairing a symposium at this Association for Behavioral and Cognitive Therapies conference last November. And Lars Mellom and his colleagues in Norway, and Emily Cooney from New Zealand, and Tina Goldstein from Pittsburgh presented 3 separate randomized trials on adolescent DBT. And the first one, I'm going to just show you quickly. Lars is the director of the Center for Suicide Prevention in Norway, and he's brought DBT. I went out there 6 or 7 years ago, trained his staff in DBT, and they compared it to treatment enhanced care as usual. to reduce, see if we can reduce self-harm with adolescents who have 3 or more borderline criteria. And it was a randomized trial, and the good news is we have a 10-year, 1-year, 2-year, and a 10-year follow-up to come. But we're looking at self-harm, frequency, and severity of suicidal ideation, as well as depression. And then we also looked at frequency of hospitalizations, emergency room visits, and so forth. And it was a 16-week trial, so 16 weeks of DBT, twice a week, individual and skills, compared to enhanced care as usual, which was psychodynamic or CBT oriented. And they were recruited from 5 different clinics. There were psychiatrists and psychology therapists, and the DBT therapists got to adherence, which is great. And so let me just show you the results. So it was 39 DBT, 38 enhanced care as usual. They were mostly girls and about 15, 16 years of age. Okay, and the outcomes. So the patients who received DBT had significantly stronger reduction in the number of self-harm episodes, stronger decline in suicidal ideation, stronger reductions in interviewer-rated depressive symptoms, as well as hopelessness feelings, and in borderline symptoms. So we're going to do the 1-year, 2-year, and 10-year follow-up, and we'll get back to that. So finally, we really need. This article results is now submitted in press, so we're going to hopefully get that published soon. We're going to hear this afternoon from Jonah Sarno and Michelle Burke, who are doing a nice large-scale RCT right here at UCLA and University of Washington. So that's for suicidal adolescents as well. But I'm really interested to see if we can get DBT skills training into school districts and see if we can help get this as a prevention model. So maybe we can even forestall or preclude the development of borderline personality disorder in adolescence and young adulthood if we can actually give some life skills earlier in life to help them manage their distress. So finally, youth is a time of opportunity, but also a time of risk. And the risk for us is that if we fail to support the rapidly growing population of young people around the world, we'll be left to pick up the pieces. Thank you very much.